I'm Patricia Pellikka, Professor of Medicine at Mayo Clinic in Rochester, Minnesota, where I'm also the Director of the Echocardiography Laboratory. Today, I'm in Boston at the World Congress on Heart Disease, and I gave a presentation on low-gradient severe aortic stenosis. Echocardiography has become our cornerstone of evaluation of patients with aortic stenosis. Accurate assessment is very crucial, and we need to accurately identify patients who have aortic stenosis, correctly recognize its severity. Unfortunately, we have no medical treatments to alter the progression of this serious and progressive disorder. Therefore, accurate recognition is important for care of our patients. And we need to know when the disease is severe and when to refer patients for aortic valve intervention and what type of valve replacement they should receive. Now, there are a lot of confusion regarding the situation of low-gradient aortic stenosis and what that constitutes. Low-gradient severe aortic stenosis refers to the situation in which there is a mismatch between the aortic valve area, which severe is defined as a valve area of less than 1 centimeter squared, and the gradient, which in the severe state is usually more than 40 millimeters mercury, but in the low gradient state is less than that. So we have a situation in which the gradient is lower than expected, but the valve area suggests severe stenosis. A number of things can account for that. One thing can be measurement error, and we have to be meticulous in the echo lab about accurately measuring the left ventricular outflow tract diameter, because that measurement is squared, and also measuring the left ventricular outflow tract time velocity integral correctly. If we've ruled out measurement error, another possibility is just an inherent discordance between the valve area and the gradient, because the Gorlin equation suggests that there actually is a slight discordance between those measurements, and that a gradient of 40 millimeters mercury corresponds more accurately to a valve area of about 0.8 centimeters squared. Besides that, there's a situation of patients with a small body size. In fact, a patient with a valve area of 1 and a very small body size may actually have more moderate aortic stenosis. Then there's the condition where the ejection fraction is reduced. If the ventricle is unable to generate a high pressure gradient, we'll have a low gradient state. Dobutamine stress echocardiography can be helpful in evaluating such patients. And then finally, there are the paradoxical situations in which the stroke volume index is reduced. The state of reduction is usually defined as less than 35 cc's per meter squared. And causes of that can be such things as regurgitation of the mitral or tricuspid valves. Part of the blood is going backwards, so the stroke volume index is thus reduced. Or you can have cardiomyopathies, endocardiac shunts, like in patients with congenital heart disease. Or pericardial constriction can also cause a low output state. Finally, there's also the situation, the classic paradoxical situation, in which the heart has remodeled in such a way that the left ventricular chamber size is small. These patients have increased thickness of their walls, but a small left ventricular cavity, so the stroke volume is thus small. This often is seen in patients with atrial fibrillation and patients with a history of hypertension, perhaps suboptimally treated hypertension. But recognizing these potential circumstances as explanations for the mismatch between the stroke volume and gradient and the aortic valve area are important, so that we can identify patients and refer them to surgery. We've been interested in how some patients develop this low output state in the setting of severe aortic stenosis, and it looks like it occurs by a unique remodeling method of the left ventricle. This is important to recognize because these patients tend to have a worse outcome even with aortic valve intervention. It may be that with our more precise measures of evaluating aortic valve area with three-dimensional echocardiography and of assessing left ventricular systolic function with strain rate imaging, we will better assess patients and more accurately identify those patients who are developing adverse remodeling. However, if we have patients in whom we are convinced that aortic stenosis is severe, that the patients are symptomatic despite optimal treatment of hypertension, these patients should be referred for aortic valve replacement even if the gradient is not in the severe range.